Dear all, on behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 23rd episode of Optometry Series. The topic for today is the role of optometrist in habilitation and rehabilitation of autistic kids. I'm very happy to welcome my team members, Ms. Anshika. Hi, ma'am. Thank you so much for joining, ma'am.
Hi.
And Ms. Meenakshi. Hi, Meenakshi. So, Anshi ma'am, it's time for you to reveal the today's moderator. So, I'm very happy to welcome Kaushalya, first of all. And why Miss Kaushalya, ma'am?
So it's my pleasure to really welcome Kaushalya. Kaushalya has been my student, but right now I am very happy to see her doing wonders at Bangalore with autistic children. So I think we have Charu would be giving her introduction, but Kaushalya was the first name and we were actually looking for autistic kids. And I think even Gomati, you remember you suggesting, ma'am, why not Kaushalya? So we are waiting to get your inputs, Kaushalya, because you've been working with a lot of autistic kids on vision therapy. And I think this is the right platform for all the students to understand how an optometrist could play a major role in rehabilitating the autistic children. So thank you so much for accepting the invite and joining today, Kaushalya.
Thank you so much, ma'am. Thank you for inviting.
Thank you, ma'am. I request Ms. Charumati to say a few words about our moderator.
A warm welcome to all of you to the 23rd episode of our Optometry Series. I'm Charpati, studying third year at Dr. Agarwal's Institute of Optometry. Today, we are privileged to have with Ms. Kaushalya, a dedicated and young professional in the field of optometry. Ms. Kaushalya completed her bachelor's in optometry at SRM Medical College and Research Center in 2020. Following her academic success, she pursued a fellowship in binocular vision and vision therapy at Shankara Eye Hospital, Bangalore. Currently, she is pursuing Masters in Optometry at City University, Punjab. Since August 2021, Ms. Kaushalya has been making a significant impact as an optometrist at the Child Development Center at the CMI Hospital, Bangalore. Her work focused on behavioral optometry evaluations and managing various vision challenges in children, including conditions like cortical visual impairment, squint, amblyopia, development disorder, autism spectrum disorder, cerebral palsy, post-traumatic brain injury that affects the children's daily living activities, academics, and post-performance. We extended our warmest welcome to you, ma'am. Thank you so much for accepting to moderate our today's episode. The speaker for today is Ms. Sandhya, completed her bachelor's in optometry at ACS Medical College in 2021, pursuing master's second year at Dr. Agarwal's Institute of Optometry. Ms. Sandhya, please start your presentations on the title, The Optometrist Role in Habilitations and Rehabilitations of Autistic Kids.
Good afternoon to everyone present here. Today I am here to present the topic on habilitation and rehabilitation of autistic kids and optometrist role. So introduction. So what is autism? Let's start with definition. Autism is a neurological disorder that affects an individual's ability to process information from the senses and multiple areas of the brain. So the basis of this neurological problem probably begins before birth, but often cannot be recognized until several years later when the child shows problems developing skills common to others of the same age. So the child shows the problems before birth, but often cannot be recognized until several years later. So the global prevalence of autism spectrum disorder is 0.62%, that is 62 per 10,000 population, also 33.4 per 1,000 population. So it majorly affects male children compared to female children. So the study proves that autism is mostly due to the genetic and hereditary factors, but also there are other etiologies for autism spectrum disorder that includes yeast infection, food intolerance, leaky gut syndrome, diets with gluten, seizures and epilepsy, brain injury at the time of birth, vaccines, and genetics. These are the other etiology of ASD. So let's come into symptoms. Symptoms in children with autism. There are visual symptoms which we will see detailed in upcoming slides. So visual symptoms are poor eye contact, difficulty attaining visually, excessive visual searching, unusual reaction to sight. So we'll see in detail. Other symptoms that are maybe social symptoms, that is language delay and or deficit. The kid with autism will have a communication impairment, social impairment, lack of facial expression, difficulty carrying a conversation, that is communication impairment, meaningless language and use repetitive languages. Repetitive behaviors can include repetitive and obsessive interest to specific parts of an object. Social problem, social impairment, unusual reaction to sound, taste, touch, or smell, unusual developmental ability, scattered strength and weakness. These are the symptoms shown in children with autism. So let's see in detail about visual symptoms, that is common visual deficits in children with autism. So first comes to visual spatial processing. What is visual spatial? Visual spatial is aware, that is a child aware of where their body is in space before they can accurately localize the target. Also the eye body control, knowing where we are in relation to other people and to our surroundings. This is visual spatial processing. There will be a deficit in visual spatial processing in kids with autism. And photosensitivity, decreased processing of peripheral stimuli, reduced visual closure perceptual ability, reduced sensory integration, reduced processing of faces and motion processing. As we see in symptoms, kids with autism, they have a lack in facial expression. So reduced processing of faces and motion processing. Visual spatial and visual motor processing include visual neglect, anomalies, reduced convergence. Signs in children with autism. These are the signs. Squints or closes an eye, looks at objects sideways or with quick glance, sensitivity to light, becomes confused at changes in flooring or on stairways, has difficulty making eye contact, touches walls or tables while moving through space, flaps hands, flicks objects in front of the eye, stares at certain objects or patterns. These are the signs usually seen in children with autism. Majorly, they have difficulty making an eye contact and the squints or closes an eye. So let's get into neurochemistry seen in autism kids. So these are the major areas implicated in autism. So majorly we'll see about cerebral cortex and cerebellum. Cerebral cortex, which is responsible for higher mental function, general movement, perception, and behavioral reaction. This area will be implicated in autism. And cerebellum, uh, located at the back of the brain, it fine tunes our motor activity, regulates balance, body movement, coordination, and the muscle used in speaking. So let's see the relationship between neurochemistry and autism spectrum disorder. So the serotonin the dietary decrease in serotonin may increase the symptoms of autism spectrum disorder. So insufficient norepinephrine, which is responsible for visual attention or attention areas controlled by norepinephrine. So insufficient norepinephrine is affected in autism. And acetylcholine. Acetylcholine is responsible for cognitive functions. Cognitive deficiencies may be influenced by disruption in the cholinergic system. Oxytocin. Oxytocin plays an important role in social behavior. So decrease in oxytocin may play a major role in social impairment. So there is also known as brain derived neurotropic factor, which is a protein. So it helps in development of neuronal system. So it may be significantly reduced in autism. So let's see about vision information processing and autism. There is a significant decrease in monocular and binocular vision for distance and near in autism kids compared to the same age group children. So spherical equivalent refractive error did not differ between ASD, that is autism spectrum disorder, and TD children. TD children is nothing but a typical developing children. So the magnitude of refractive error has been found to be significant in up to 44% of individuals with autism. And intermittent strabismus has been found in children with autism, with rates ranging from approximately 21% to 84% of population. These are the vision and visual information processing in autism. Let's see about primitive reflexes before going into these topics. So the individuals with autism may feel a difficulty in some areas that are orientation, gross motor, eye movement, and communication, focusing ability, that is accommodation. There are many areas they feel difficulty, and they're also retained primitive reflex can cause disturbance to the individuals with autism. So let's see in detail about these areas and how can we manage these areas. So coming into primitive reflexes are involuntary motor responses originating in the brainstem present after birth in early childhood development facilitate survival. So these motor responses are eventually inhibited by 4 to 6 months of age. So these primitive reflexes will be inhibited by 4 to 6 months of ages as the brain matures and replaces them with voluntary motor activities. So if these primitive reflexes are retained, so there will be a disturbance. So what happens when these primitive reflexes are retained? Primitive reflexes help to coordinate the fine movements of muscles, gain accurate accommodative abilities, and develop fusion and fixation and convergence. So lack of integration of various primitive reflexes can have following consequences. There are 4 reflexes. Mororeflex, if it remains active for too long, that is, if it is retained for more than 4 to 6 months, the child can be more sensitive to bright light, sound, movement, or any alteration in the visual field. TLR, if TLR is retained, may affect the development of postural reflex, balance, poor visual information processing, and cause difficulty with spatial judgments. ATNR. A retained ATNR may affect development and function in establishing hand, leg, eye preference, or body dominances. Problems with ocular dominance can affect reading, writing, and spelling. So if we train these reflexes, there may be an improvement where it is affected. So in ATNR, if it is retained, it affects the reading, writing, and spelling. If we train the autistic kids with the exercises, they can improve in areas like reading, writing, and spelling. So STNR, a retained STNR can affect the proper development of upper and lower body coordination, gross pattern movement, and the poor eye-hand coordination. This is about primitive reflexes. So comes to eye movement. So ASD exhibits impaired perception of motion and poor or atypical visual tracking of social stimuli. If there is an abnormal eye movement, that is saccadic dynamics, such as reduced peak, such as reduced peak velocity, increased duration, increased rate of prosaccades, and suppression errors have been reported in the past. And sensory motor impairment of abnormal oculomotor behavior in ASD are associated with the structural and functional abnormalities in brainstem and the cerebellum. As we've seen before, there is major areas implicated in autism are cerebral cortex, brainstem, and cerebellum. We have seen it in previous slides. So additional functions and sensory motor control of eye movements are crucial for learning to navigate in social and physical development. Dysfunction intercepts social interaction and communication. So how we diagnose autism? There is a diagnostic criteria for autism, which is DSM-5. So according to this DSM-5, we can diagnose the autism. How we will diagnose? A child must have persistent deficient in each of three areas of social communication and interaction. So the child should have deficits in areas of social communication and interaction area, and at least 2 or 4 types of restrictive repetitive behavior. So there is a level of severity, that is level 3, which requires very substantial support. Level 2 requires substantial support. Level 1 requires support. So if we are planning to start a multidisciplinary team approach for an autistic kid, we should know the complete information of the kid from the parents. So the subject's parents provided information regarding their children's level of verbal communication, not only verbal communication. So we can add many things as we've seen before, the eye movements, primitive reflexes. So many things can be added. So when it comes to communication, we specifically indicate if their child was best described non-verbal, minimally verbal, uses short words, can answer questions partially, verbal, speak fluently, able to answer questions completely. So autism kids, some kids can be non-verbal, some kids can be partially verbal, and some can some can be fluently speak. So these things should be noted from the parents. What is visual behavior? So observation. So what we observe when we are handling the autistic kid, looking at an object while tilting head or looking through the corner of the eye, repetitious movements of the fingers, hands, stereotypic behavior such as fixating on windows and blinds, poor eye contact, poor eye tracking, gaze aversion. So, and fixation skills are the most important reasons that contributes to the particular behavior. Lateral version, that is nothing but looking through the corner of the eyes, which can be seen in many autistic kids, has been attributed to faculty behavior, by faculty binocular processing, which is due to the fault in binocular processing and poor interhemispheric integration. So poor eye contact, poor tracking, and lateral version should be considered when we are observing the kid. So orientation, what is orientation? How we should manage? So orientation can be viewed as eye-body control, which is essential to knowing where we are in relation to other people and to our surroundings. So this is orientation. So individual with difficulty in visual orientation, how they will behave. They have trouble in sitting still, concentrating, and staying on task with reading and writing. In these areas, they will have difficulty. So how to manage? If we manage this orientation by using a multidisciplinary team approach, there will be a success. Since the orientation is managed, they able to sit still, stay on task, on direct concentration. So other observed behaviors are distractibility and difficulty staying on task, that is visual attention. So comes to gross motor and spatial orientation. Gross motor controls include bilateral coordination, visual motor integration, and body awareness. Let's see each in detail. What is bilateral coordination? Bilateral coordination allows the children to differentiate right from left, so, and to gain an inherent knowledge of midline and laterality. Visual motor integration enables the child to transition from motor to vision as a primary learning modality. So as we seen before, so the child with autism, they feel difficulty in differentiating right from left. If we are going to manage this, we have to incorporate the activities more on right or left awareness, and visual motor integration activities should be improved. The child must also be aware of where their body is in space before they can accurately localize target. Binocular problems encompass difficulty in coordinating and using both eyes. Visual unification occurs as one utilizes past experience and correlates information from all areas of vision with inputs from other sensory systems. This overseeing operation of vision embraces many functions often classified as visual perception. So visual unification is nothing but utilizing the past experience and to correlate this information into present. So as we seen before, the kids with autism have a difficulty in communication. Let's see in detail about communication. People with autism often have communication difficulties in one form or another. There are some people with autism who speak frequently. We have seen this before. So others who have speech impaired to varying degrees, and others still who are able to speak at all. Lines of conversation in ASD may involve repeating phrases or words, so as we seen in signs and symptoms, or asking the same questions repeatedly. Impairment of these skills may result in delayed speech and uh, poor acquisition of language and communication. So let's come to team approach. Uh, Autism requires an interprofessional team of speech, occupational, physical, and behavior. So we need a multidisciplinary team which have occupational, physical, behavioral, vision. So vision therapy should also be included in conjunction with these therapies, that is occupational, physical, behavioral, speech, to improve visual coordination, visual motor integration, and visual information processing, nothing but a visual perception. So signs of atypical neurobehavioral development may therefore be rooted in oculovisual, cognitive, language factors, or their interrelationship, and are increasingly acknowledged to require yearly identification and a multidisciplinary treatment approach. So eye care professionals play an important role in a yearly diagnosis of autism, or they can identify yearly. So eye care professionals play a major role in diagnosis of autism. Role of optometry. The optometrist role should include the diagnosis and treatment of any ocular pathology, vision dysfunction, visual perception anomaly, and refractive error present in an autism kit. So optometric utilization of various targets used for diagnostic testing in infant toddlers may be among the earliest probes of preferred visual looking patterns conducted within this population. So they potentially identify infants and young children at risk for developing ASD characteristics. So, eye care professional optometrists play an important role in identifying the risk for developing ASD. The optometric role is to allow the autistic kid to visually relate to this environment in more appropriate way, as well as to utilize the visual system functions more appropriately. As we seen earlier, the autistic kid can be verbal, can be non-verbal, and some can be fluently verbal. So in that cases, how can we assess the vision? So we can use the preferred visual looking patterns, and there are some other diagnostic testing for vision. we can incorporate in the to identify the developing ASD characteristics. So vision therapy activities are yoke prism, which plays a major role. So when the patient is able to accomplish the activity with altered sensory input provided by the yoke prism, more refined, flexible, and adaptive motor control is exhibited. So yoke prism, when used for therapy in higher amounts, initially creates a mismatch between the visual and vestibular proprioceptive pathways. Yoke prism may also help to improve posture, walking, balance when used in various different gaze directions. So the use of low plus lenses may help in expanding visual space volume and emphasizing the figure against the ground. This can serve as a aid to improving attention, focus, and speed to near visual targets. Near visual tasks. So your prism plays a major role in vision therapy. The utility of binasal occlusion has also been demonstrated in studies as evidenced through improved binocularity and enhanced peripheral awareness. As we seen before in symptoms, the kids with autism may have a lack of peripheral stimuli. So by incorporating binasal occlusion in a spectacle, which has been used by autistic kids, which can enhance the peripheral awareness. Yoga prism also to expand the body balance range while maintaining visual targets. So this is the kit which have different yoga prism can be in different powers. So how can we, as we seen before, there are lack in some areas, that is orientation, facial orientation, eye movement, and communication. So how we manage these areas, and vision therapy can be used to improve these areas. So how we improve the orientation by throwing and catching cues, and this is a tape walking, walking in a line, and body awareness activities. So these can be can be incorporated in patients' daily tasks to improve the coordination. Primitive reflexes. So primitive reflexes is retained in some kids. So to improve that, we can teach, we can use more like primitive reflexes in vision therapy, which can be both in home and in office. So we should teach the parents so how we do these reflexes, and the parents should continue this reflex training both in home, and when the patient is coming to the in-office therapy, we can still do these reflexes. Uh, at first the child at first when we are teaching, uh, the the child will be dependent on us when doing this reflexes. So when but gradually the child will become independent. They will do this reflexes on their own. So by doing this reflexes, so when it is retained, what are all the things the child can experience when we are doing this therapy, it will improve all these areas, and like development of posture, reflex, balance, there will be a good visual information or eye body coordination. These things will be there. So eye movements, saccades and pursuits, how we train the saccades and pursuits, we can use a pegboard, rotational pegboard, and master ball tracking, catching, tapping, and rotational charts. There are several apps with these rotational charts or rotational games. SBI Sagnet Vision Integrator. We can use this for both eye movements, saccades, pursuits, and also we can use it for rotational use as a rotational chart. So how we improve saccade? There is a thing called four saccadic chart, and we have separate workbook for saccade, which is from Bernal. So when we are training a kid with these activities, their saccade, pursuits and eye movements will improve. So we have to instruct the child like in four saccadic chart. So four charts with 5 rows and 5 columns. We have to place it in 4 corners. So we should instruct the child to read as the first letter in first row. So by when they are moving their eye from one letter to other letter which is placed in the corner, the saccadic movement will improve. So we should follow these patterns. It can be they can read in both vertical and horizontal manner. So accommodation focusing ability is also affected in kids with autism. So how to improve this accommodation? We can use loose prisms with hard chart and flippers with hard chart, loose plus lens with hard chart, and both near and distance hard chart can be used to improve the accommodation area. And vergence activity, for vergence activity, we can use Brock string and we can use BTS. So it is a software which have vergence activities. So we can adjust the distance and we can, if the patient is improving in near distance, we can improve the distance to long and we can train the vergence activity. And visual attention and space. As we seen earlier, we have seen the definition for visual attention and space, visual attention and span. We can improve the visual attention and span by our daily activities also. And there is a software called a computer perceptual therapy. As we can see here, there is a term called visual span, visual attention. By doing these therapies, we can improve their visual attention and span. So visual information processing. So visual information processing is nothing but a visual perception. Visual perception activities can be improved. They have many softwares to improve the visual perception activity. There is a HiBab software and CPT, as we seen earlier, computer perceptual therapy, which also have a visual perception activity. And IPAP can also be used to improve our orientation, like to differentiate between left and right, so body awareness, to copy to copy the left and right, how to jump from right to left. So these things are available in IDAP. We can use this software to train the kids. And packwitry block, as we can see here, the block should be placed according to the color and pattern we can see in here. There are different sheets and we should match the color and shape according to that pattern. So these things will improve the visual perception of a kid. So we see in the activities. Now we will see the strategies which should be incorporated in optometric vision therapy. So challenges, difficulty in transitioning between activities. Implement activity schedules or social stories, gradually change activities, offer choices. So when we are doing a therapy for a kid, we should not do same activities for a prolonged time. So we can ask the kid which activity they like. So we can change the preference. So we can offer choices and gradually change the activities instead of doing the same activities for same activities daily. Difficulty understanding verbal instruction. So for this case, we can use videos or visual stimuli instead of giving a verbal instruction, pictures for each activity. Difficulty with hyper or hyposensitivity to sensory stimulation. Follow sensory supports and slowly emphasize sensory integration to improve compliance and motor balancing. So as these sensory supports and motor sensory integration is improving, we can advance the training. We can add balance code when doing the eye movements activity, like saccades, pursuits, or when reading a rotational chart. We can use metronome, which is available in YouTube also. So we have different beats per minute. We can incorporate balance board with balance board and metronome reading when the treatment advances, and vertical yaw prism to create an image shift requiring a motor response to sensory mismatch in space. Reduced motor planning ability, increased restlessness and clumsiness during the therapy. So if there is a increased restlessness and clumsiness during the therapy, incorporate rhythmic movement, incorporate gross motor activities like jumping in different direction. As we see in, like to differentiate between right and left, we can use the right and left jumping also. We can ask the kid to jump towards right or left when we are showing a direction arrows, or balance beam while reading a letter chart. Anxiety, poor attention, and inability to generalize learned ideas. So when a kid have a poor attention, so we can ask questions like, if, for example, if we are doing vectogram procedure, we can ask the patient if there is a two circle, or what do you think your eyes are doing? If the images seems to come closer to you or far from you, what could that mean about how you are controlling your eyes? So we can keep the children actively, and we can ask the questions and improve their attention skills. Incorporate problem solving techniques and repeated practice and abstract reasoning. Poor ability to relate to therapists and develop meaningful play. Matching patients' developmental level and interacting in a way that are meaningful and enjoyable. So we should interact with the kids like joyfully, or what makes them happy. We should be friendly with them. So this may develop a meaningful play. So summary, with the help of these multidisciplinary clinical practice models to improve the emotional, communicative, and motor development of a kid with ASD, optometrists can improve the effectiveness of vision therapy to promote better visual comfort in this patient's daily life. Vision therapies not only can improve their academic function with multidisciplinary modification, but can improve their emotional and social functions. So integrating primitive reflexes therapy along with routine vision therapy and home therapy. So as I said before, routine primitive reflex therapy can be incorporated in home also, plays an important role in overall treatment plan and positive outcome for patient on autistic spectrum. So treating ocular motility disorder in autistic children may require providing support for deficiencies in gross motor ability in conjunction with modified techniques that reflect their developmental level. So these are all my references. Thank you.
Thank you, Sandhya. It was an extensive presentation.
Thank you, ma'am.
It was a very detailed explanation about the autism. Now I would welcome Ms. Kaushalya for explaining about the habilitation part of autism kids.
So good afternoon, everyone. I'm happy to be here today. And thank you, Anshi ma'am and Charumati, for the kind introduction. And Sandhya, it was a very good presentation, and it was a very detailed presentation. And to summarize and emphasize on autism and habilitations. So autism is a spectrum disorder, as the name suggests. It is an umbrella term where in one end, a child might have like autism might interfere in their daily living activities, and in the other end, autism is associated with either a gifted syndrome, or it can be a plus point for them. If you take Albert Einstein, is known to have autism, and the one of the common sign associated with autism is poor eye contact, and autism is also associated with many difficulties in many domains like sensory processing, gross motor processings, vision processing, and regression in speech, and all those things. And as when we come to eye contact, so they will try to avoid eye contact and look away. So gaze aversion, it can be because of poor fixation ability. So when they have poor fixation ability and poor visual skills, it is getting difficult for them to either fixate at a person's eye and communicate, or it is getting overwhelming and they are feeling anxiety, so they are trying to gaze aversion and look away. And one more common thing is eye movement. Saccadic and pursuit ability is poor, so they'll try to use their head movements to follow moving objects. So if you see, we had a kid who used to be afraid of strollers. So if we see baby stroller in street, he will just lose it and start showing tantrums. And many kids doesn't like any moving objects or moving vehicles or moving letters in the ad, and that will create anxiety and they will get overwhelming. So they'll have many behavioral issues and all. So in another and when eye movement is poor, if you have to read for skipping, like from moving from one letter to letter or moving from one word to word, we need a good second ability. When that is difficult, they will have learning disabilities or difficulties in learning reading difficulties. So they'll have common complaints like he will skip reading, skip word while reading, skip line while reading, and all those things will be there. And disinterest for reading will be there. And another one is poor convergence ability. So when they have poor convergence ability or they have poor binocular vision, so maybe they are seeing double vision or it is stressful for them to maintain single vision. So they'll have other adaptation called visual stimming, so like hand flapping. And if you see, hand flapping also have many perspective. So one of that is if they are flapping their hand in front of one eye, it can be because they are trying to use only monocular vision and just try to avoid double vision diplopia or binocular vision stress. And one more thing is poking of eye. So when you try to poke your eyes, you will see double vision. So maybe they are seeing it double and they are trying to poke their eyes to make it single and to avoid diplopia. And other adaptations stemming like what Sandhya mentioned, they'll have peripheral gazing or side gazing. So they'll look through their corner of eyes. Again, they are trying to use just monocular vision to avoid diplopia and stress because of binocular vision. So all those things are common. And one more thing is their vision, like tunnel vision, they'll have tunnel vision, and vision is restricted to the center. Because of that, peripheral awareness is poor. And when that is there, hypersensitivity to vision will be there. So for every visual stimuli, they'll get hyper or excited. They will try to stiffen their body. So instead of reacting to the visual stimuli, they'll just freeze there. So imagine if they have to cross the road, a vehicle is coming. Instead of reacting, if they are freezing there, again it is going to interfere their daily living activities. And they tend to have many color preferences. So some might have yellow color preference because it is high luminance color, and some might have blue or green color preference because it is calming for them. And they tend to have many behavioral issues because they are trying to adapt for some. They're having some difficulties and they're trying to adapt for it. So that's how they have poor eye contact and poor. Um, they're trying to avoid reading and they're trying to move around a lot instead of sitting. They will have poor sitting tolerance and all. And so and they will also have associated sensory difficulties. So their habilitation will go with the multidisciplinary setup. They might need one or multiple therapies like occupational therapist help, speech therapist, and vision therapist. So through vision, we'll be helping them in improving their visual abilities. So we'll start with fixation ability. How is their fixation ability? So we'll have to work on fixation so that they can observe and learn from it. Learn from their environment, their daily living activity will improve. So if you see, 80% of learning goes through vision. So when vision is difficult, again, or other all other learnings are going to be interfered. So other improvements in other therapies also are going to be difficult and slow. So when you integrate with the visual therapy, then it is going to be better. So and they're known to have poor spatial perception. So if ball play and any sports activities will be difficult. And if you see many kids, they'll just try to avoid ball plays and all. If ball is coming, they'll just look away, or they'll not even show interest to play with balls, or they don't like to interact with other people and all. It can be because of vision again. When convergence is poor, if a ball is coming towards you and you have to converge accordingly and coordinate your eyes, and your peripheral vision has to be good to understand the space. And when that is difficult, again, it is going to be difficult for them to involve in sports activities and all. So we'll have to work on their visual skills and all their daily living activities, and their quality of life will improve. So as such, we cannot cure autism, but we can help them in improving their quality of life. So so when in these vision things and all, it is difficult for other practitioners to understand. Even if they understand and they refer for vision assessment, again, it is being missed out, because as a regular practitioner, we will do refraction and we will do vision assessment, and we'll think, okay, 6 vision is there, or if we need glasses, we'll prescribe glasses and say, you don't have any other vision difficulties, you can carry on with this. But that's not it, because we have to evaluate other behavioral aspect of vision. Mm, Autism kids might have, in majority of the cases, they have 6 vision, and refractive errors also are very less. If they have, in majority, they might have withdrawal astigmatism, which can be corrected by glasses. But that's not it. That is just clarity of vision. But other behavioral aspect is going to interfere in their daily living activities, which has to be grasped by us, and we have to improve that in coming years. So that's it. If you have any questions or anything to say.
Thank you so much, Kausalya.
Yeah.
Just a few summary points for the student's perspective. If you get a kid with autism, how will we start assessing them and what kind of training will be initiated at first?
Again, yeah. So for assessment, the keyword, magic word is observation. So we observe, and observe the kid, and we learn from the behaviors. So like I said, they might not sit and cooperate for assessment. I cannot expect the kid to read a visual acuity chart or sit for half an hour, 20 minutes to do all the binocular vision assessment. So you can just give some video, or you can just let them in the environment and start observing. So are they doing side gazing? Are they trying to avoid eye contact? If they're watching video, how are they watching? Are they able to sit for at least 10 minutes? Are they able to maintain their fixation for 10-20 minutes, or show some interesting object? Are they able to maintain their fixation? So that way we can understand their fixation ability, and we can understand if there is any squint by observation. So, and then we can move the target slowly, and then we can see if pursuit is good, or they're using head movement, or they're getting restless or anxious with the testing. Then we will know eye movement is difficult, so we have to work on eye movement. And then we can we can show one object of interest and slowly move it towards them and see how the convergence ability is. So with that, we can understand their binocular vision. And with the behavior, a lot of things we can understand. So from are they going near the computer and watching TV or computer or phone, or from distance, how are they watching? Are they able to do it, or they are trying to go closer again? Are they trying to move? So all these things will help us understand what they are going through and help them. So that's how we go about their assessment. And therapies, again, we cannot expect them to do a vectogram or a traneglyph. So we will innovate the therapy accordingly, according to their cognition level and age. So if a kid is verbal, again, we can use heart chart, any reading material, four second charts, and we have softwares, SVI, Visho Prime, all those things we can use. And if a kid is non-verbal, again, we can use any toys, object of interest. So Marsden ball we can use for convergence, peripheral vision, and spatial perceptions. And we can use puzzles, so searching for particular item in a messy area. So all these things, so if that we can incorporate with toys, or which things they like. So many autism kids are known to be obsessed with letters, so we can do a lot of therapy with alphabets also, searching the alphabets. So crowding, we can create one crowding area and ask them to search for alphabets. Again, that is going to help them improve eye movements and convergence. They have to fixate, then only they can search. So fixation, and if they have to take, again, eye hand coordination. So like that we will innovate the therapies. And we can use beads or stick. With the beads and stick we can work, or we can use beanbag tossing. So we will do therapies like that. If they are verbal kids, then again we can use vectograms or block strings. And
You. The next question will be, how long does the effect of vision therapy stay? And will the child need to have vision therapy throughout the life?
so it is depending on their ability. So it might take a long time. How much time it is going to take, it is depending on the individual. Time will vary depending on the individual again. So it will take few months for them, few months to few years, to improve their abilities. But once the ability improves, we'll stabilize the abilities by integrating it with vestibular inputs, auditory input, and other senses. So once that is integrated and that is stable, and then we can stop, and they might not need to continue the therapy. They can just do few activities at home to maintain it, and then we can stop it.
And the next one will be, we all know the environment for the autism kids is very, very important. To bring up them for a particular place, make them to do activities, it's all challenging. But just to know, now the vision therapy is getting converted to application-based therapy also. Will autism kids do application therapies at home, or it's only in-office therapy for autism?
No, they'll have to do at home also. So when they come for vision therapy, we'll be teaching them what all they can do at home, and what are the changes they'll have to do. So all those things they have to continue at home. So if a kid is having a difficulty in navigating in a crowding area, so initially will not suggest them to go into the crowding area. So we'll have to work on other things, and then they can go into the crowded area. So those environmental modification will be happening at home also. And whichever activities we are doing during therapies, we cannot actually, it has to be done every day, but we cannot do every day, and or 24 hours also we cannot do all the changes. So we'll be doing 45 minutes in alternative days, or depending on their abilities, and we'll give changes and what all the activities they can do at homes, and they'll be continuing that at home also.
Thank you so much, Ms. Kaushalya. Now I request Anshi ma'am, if she has any questions, please ask us now.
No, I don't think I have any questions. It was such a detailed presentation, and we had almost all the questions answered. So thank you, Sandhya, and thank you, Kausalya, for such a detailed session. And I think everybody would have loved to hear the session, keep hearing again and again to keep learning more from this. So over to Gomati.
Thank you so much, Kaushalya ma'am. Thank you so much, Kaushalya, for joining us once again. Thank you so much.
Thank you, ma'am. Thank you.
So, dear audiences, sorry for the technical issue from our side. This video is not live for now, but you'll be able to see this video. When you're able to see this video, just make sure to ask your questions in the comment box. We'll get back to you with the answers. The announcement for this week is 3 fellowship courses are up and admission is are opening on January. So, Anshika ma'am, can you please share about the courses on fellowship?
Yes, so we have 3 fellowship courses. The first one is a fellowship in clinical optometry, which is there for 6 months as well as for 1 year. The second one is fellowship in pediatric optometry, and the third one is fellowship with advanced research, which is for a year. In fellowship in advanced research, we have 4 months of complete research and 8 months of clinical optometry. So definitely, those who are interested, please do contact us, and so that we can start ASAP from the month of January.
And all these courses are along with the stipend. So if you are interested, please enroll with us. There are limited seats only. To know about these details, please contact the course coordinator. I'll be giving a contact number in the description box. To know more about what is happening at Dr. Agarwal's Institute of Optometry, please do follow us on Instagram, Facebook, and LinkedIn. The links for those are given in the description box. Happy New Year to each and every one of you from the team of Dr. Agarwal's Institute of Optometry. Meet you all in the next episode. Tata, bye.
Thank you.
Thank you.